Imagine for a second that you're sitting in the quiet hum of the clinic's reading room.
Yeah, we've all been there, right?
Exactly. You pull up the latest restaging scans for a patient with, recurrent head and neck squamous cell carcinoma.
And you just know their history by heart at that point.
You really do. I mean, they've already been through this grueling gauntlet of platinum-based chemotherapy,
Right.
and they've had all their hopes pinned on a PD-L1 immune checkpoint inhibitor.
Which obviously brings a pretty high toxicity burden with it.
Yeah, the toxicity burden is already so high. And yet right there on the high-definition monitor, you see those undeniable white shapes.
The disease has progressed.
Yeah.
Yeah.
The tumor is growing again. It's just, it's this heavy sinking moment that every clinical oncologist knows all too well.
It really is. I mean, it's the point in the clinical trajectory where our established, high-confidence algorithms essentially just run dry.
Right, the playbook is empty.
Exactly. We move from definitive curative intent, or even robust first-line palliative control, into this space where the therapeutic window is incredibly narrow.
Because the patient is so battered by this point.
Yeah, the patient is battered and the tumor is highly adapted. And, the subsequent options we have often carry toxicity profiles that, quite frankly, heavily outweigh their historical efficacy.
So if you treat or study head and neck cancers, you live with that absolute frustration.
You really do.
Managing patients whose disease has progressed after platinum and immunotherapy, it feels like fighting a rearguard action.
Because the options shrink so fast.
Right, and the clock is ticking loudly. We're constantly looking for a mechanism that can actually corner a tumor that has become this resilient.
And, well, today we might actually be looking at one.
Yes, welcome to this deep dive. We're speaking as fellow clinical oncology researchers today, and our mission is to dissect some highly anticipated data.
Really anticipated.
We are looking directly at the pivotal results of the Phase 1b/2 ARGAMI-4 study, specifically Cohort 1.
Right, the data that was just presented at the ASCO 2026 annual meeting.
Exactly, and it centers on subcutaneous Amivantamab as a monotherapy.
Right, specifically for patients with HPV-unrelated recurrent or metastatic head and neck squamous cell cancer.
Okay, let's unpack this, because before we can really appreciate the magnitude of this new trial, we have to establish the clinical baseline we're operating against.
Which is, honestly, a pretty bleak baseline.
It really is. What are we looking at historically here?
Well, to really grasp the implications of the ARGAMI-4 data, we have to ground ourselves in the historical comparators.
Right.
For this specific patient population, those with HPV-unrelated recurrent or metastatic disease who've already progressed on platinum and a PD-L1 inhibitor, the standard of care has often defaulted to cetuximab.
And how does that usually go?
If you look at the FAYET 2025 data, which serves as a really crucial recent benchmark here, the reality is just stark.
Yeah.
With standard cetuximab therapy in this setting, the objective response rate, or ORR, sits at a mere 24%.
Wow. So we're looking at roughly 1 in 4 patients seeing any meaningful tumor shrinkage.
Exactly. Just 1 in 4.
And even when we do capture that response, the durability is pretty fleeting, isn't it?
It is. The median progression-free survival, the PFS, is just 3.8 months.
Wait, 3.8 months? That is less than 4 months before the cancer bypasses the EGFR blockade.
Yeah, less than 4 months before it resumes its progression. That's the hurdle we are dealing with.
Less than 4 months of control for the majority of these patients? That's just incredibly tough.
It's terrible. And the brevity of that PFS, it speaks directly to the plasticity of head and neck squamous cell carcinomas.
They just adapt so quickly.
They do. These tumors are incredibly adept at finding workarounds when they're subjected to single-target selective pressure.
Which I guess brings us to the drug in this trial, Amivantamab.
Right.
We're familiar with Amivantamab as an EGFR-MET bispecific antibody, right?
Mm-hmm.
With immune cell directing activity.
Yes, that dual targeting is the key.
I want to look at the structural logic of this for a moment. I mean, we know EGFR is a classic, validated target in these cancers.
Absolutely. That's exactly the rationale behind cetuximab.
But the addition of the MET target is the critical variable here. I mean, are we just throwing 2 darts at the board and hoping one sticks?
Not at all.
Because to me, is this essentially a spatial problem? It feels like locking the front door of a house by inhibiting EGFR, feeling secure in that blockade, only to realize the tumor has quietly escaped out the back door using the MET pathways.
What's fascinating here is that analogy perfectly captures the mechanism of acquired resistance we're battling.
Oh, really?
Yeah. Under the immense selective pressure of an EGFR inhibitor, your front door, the tumor cells upregulate alternative signaling cascades.
Right, to bypass the blockade.
Exactly, to maintain their proliferation and survival. And elevated MET expression is a thoroughly documented primary escape route in recurrent and metastatic HNSCC.
So the tumor literally just throws the back door wide
It
open,
does.
which means leaving the back door unguarded renders the front door lock entirely moot within a matter of months.
Yes.
And that explains that 3.8-month historical PFS we see with cetuximab.
That's exactly it. And the architectural design of Amivantamab directly addresses that bypass mechanism.
Because it hits both at once.
Right. Because it is a bispecific antibody, it's engineered to bind to the extracellular domains of both EGFR and MET simultaneously.
That's elegant.
It really is. It shuts down the primary oncogenic driver and the most common bypass track at the exact same time.
And there's an immune component too, right?
Yeah. Furthermore, its IgG1 backbone facilitates Fc-mediated immune functions, specifically antibody-dependent cellular cytotoxicity and macrophage trogocytosis.
So beyond just signal inhibition, it physically flags the tumor cell for destruction by the innate immune system.
Precisely. It's a multifaceted blockade against a highly adaptable tumor.
That makes a lot of sense. And, regarding the OrigAMI-4 trial design, there's a crucial exclusionary criterion we need to highlight for anyone analyzing this data.
Oh, definitely. The prior therapies.
Yeah. Prior anti-EGFR therapy was strictly exclusionary for this specific cohort.
Which is so important to remember.
Right. The investigators deliberately selected for tumors that had not already been exposed to an EGFR-only blockade.
They wanted a pristine look.
Exactly. A pristine look at the efficacy of shutting down both the EGFR and MET pathways simultaneously from the very start, rather than, trying to salvage a tumor that had already developed complex, multi-layered resistance mechanisms to cetuximab.
That trial design choice is just vital for interpreting the readouts.
How so?
Well, testing the dual mechanism in an anti-EGFR naive population allows us to see the true ceiling of this bispecific approach.
Right, without all the baggage of prior targeted resistance.
Exactly. I mean, elegant biology in the preclinical models is a prerequisite, sure, but translating that dual mechanism logic into a robust clinical signal for patients who have exhausted their standard lines of therapy, that's the ultimate test.
And looking at the data from ASCO 2026, it suggests that translation is actually happening.
It really does. Let's break down the efficacy metrics from the January 6, 2026 data cutoff.
Okay, let's look at the numbers.
So the cohort was fully enrolled with 102 patients who had received at least one dose of the subcutaneous Amivantamab.
And just to reiterate, 100% of these patients had received prior PD-L1 inhibitors and platinum-based chemotherapy.
Right. So in that heavily pretreated refractory setting, the confirmed ORR was 47%.
47%. That represents a near doubling of the historical 24% baseline we discussed with standard single-agent EGFR inhibition.
A near doubling. And peeling back the layers of that 47%, we are looking at 4 complete responses.
4 patients achieved a CR in a post-platinum, post-IO recurrent setting. That is incredible.
It really is. Plus, there were 44 partial responses, and 39 patients achieved stable disease.
So a lot of disease control happening there.
Yeah, when you aggregate those numbers and look at the waterfall plots, 79% of the patients in this cohort experienced some degree of shrinkage in their target lesions.
Nearly 80%. Basically, 8 out of 10 patients had a reduction in tumor burden. That's huge.
Achieving nearly an 80% target lesion reduction rate in a population where the standard expectation is rapid progression, it's a profound efficacy signal.
It really validates the whole biological theory we were just talking about.
It strongly validates the hypothesis that simultaneous EGFR-MET blockade functionally cuts off the tumor's primary evolutionary escape route. We are seeing the actual clinical manifestation of that dual pathway inhibition.
But here's where it gets really interesting. We're accustomed to evaluating the depth of response, sure, but the kinetics of this drug are equally compelling.
The speed of it.
Yes. The data shows that the median time to initial response was just 6.6 weeks.
Wow.
Patients are seeing clinical measurable benefits in roughly a month and a half.
That is so fast.
And in head and neck oncology, where local tumor progression can acutely compromise the airway, impair swallowing, and cause debilitating pain, that rapid onset of action is not just a statistical victory.
No, absolutely not.
It's a critical organ-preserving and symptom-relieving characteristic.
The anatomical real estate involved in HNSCC means that time is rarely a luxury we possess.
Yeah, exactly. You don't have months to wait and see.
Right. A rapid, deep response can literally mean the difference between a patient maintaining their native airway or requiring an emergency tracheostomy.
It alters the immediate clinical trajectory and the patient's symptom burden dramatically.
But, the rapid onset is undeniable. But the lingering question with any fast-acting targeted therapy is always durability.
Yeah, we've all seen therapies in oncology that act fast but fizzle out just as quickly.
Right. We frequently observe profound initial responses that just fade once the tumor inevitably finds a tertiary escape mechanism.
The scans look brilliant at week 8, and then by week 16, the progression has resumed. Does this response actually last for these patients?
Well, if we connect this to the bigger picture, the durability data from Oregon 4 is what elevates this from interesting biological proof of concept to a potential practice-changing regimen.
Okay, let's hear the durability numbers.
Among the confirmed responders in this cohort, the median duration of response, the DOR, was 7.2 months.
Over 7 months of sustained response in this setting. That's a massive shift from the baseline.
It is. And the median PFS reached 6.8 months.
Wow. Contextualizing that 6.8-month PFS against the Fayette 2025 cetuximab benchmark of 3.8 months, we are looking at nearly a 100% increase in progression-free survival time.
Almost doubling the time without progression. And we really must factor in the physiological state of the patients achieving these outcomes.
Right. Who are these patients?
The median age in cohort 1 was 63. 77% of the cohort was male, which perfectly aligns with standard HNSCC demographics.
Pretty typical.
But crucially, 67% of these patients had an ECOG performance status of 1.
Yeah, an ECOG-1 population in the post-platinum, post-IO HNSCC space is a physically compromised group.
Heavily compromised.
I mean, these patients are carrying the cumulative, lingering toxicities of their prior lines of therapy.
The neuropathies, the hearing loss.
Exactly. Chronic fatigue, often significant malnutrition and sarcopenia, just due to the location of their primary disease.
They are very functionally restricted.
So, securing a 6.8-month PFS in a symptomatic, structurally battered population really underscores the potency of the dual inhibition mechanism.
It clearly demonstrates that the drug is doing the heavy lifting, even in hosts with severely compromised physiological reserves.
But, high efficacy metrics and robust PSS curves mean very little if the toxicity profile precludes administration in a real-world community clinic setting.
That's the catch with so many promising drugs.
We have all seen highly active compounds fail in the clinic because the logistical hurdles or the adverse event profiles are simply untenable for an exhausted patient.
Absolutely. We must critically evaluate the practical realities of actually deploying this treatment.
Which brings us to the safety profile and, importantly, the specific route of administration utilized in the OrigAMI-4 trial.
Right, the subcutaneous delivery.
Yeah, the subcutaneous designation is a major logistical focal point here. The trial evaluated a sub-Q delivery method rather than a prolonged intravenous infusion.
Which is a game changer for clinic flow.
It is. Looking at the mechanics of the dosing schedule, cycle 1 day 1 involves a dose of 1,600 milligrams. And for patients weighing 80 kilograms or more, that dose is escalated to 2,240 milligrams.
Okay.
Then on cycle 1 day 8 and day 15, the dose increases to 2,400 milligrams, or 360 milligrams for the higher weight tier.
And then it spaces out.
Yeah, following that initial loading cycle, the regimen transitions to an every 3-week maintenance schedule.
Transitioning from an IV formulation to a subcutaneous injection represents a significant operational advantage for the clinic.
Oh, totally.
And a major quality of life improvement for the patient. I mean, it drastically reduces infusion chair time.
Which patients always appreciate.
Furthermore, the trial data indicates that the subcutaneous route mitigates some of the classic infusion-related toxicities. Administration-related reactions occurred in only 13% of patients in this cohort.
And drilling down into that 13%, all of the reported administration reactions were strictly grade 1 or 2 in severity.
No grade 3s.
None. There were no severe treatment-limiting systemic reactions during the subcutaneous delivery.
That's fantastic. An all grade 1 or 2 administration reaction profile at a 13% incidence rate is highly manageable for a biologic agent of this complexity.
It really is.
It allows for efficient clinic flow without requiring excessive premedication or, prolonged observation periods.
So the administration profile is clean, but I want to pivot to the overall tolerability, specifically the treatment-emergent adverse events.
Okay, let's look at the AEs.
Because looking at the data, there is a pronounced cluster of toxicities occurring in more than 25% of the patients.
Right.
We are seeing high rates of hypobuminemia, rash, dermatitis acneiform, paronychia, stomatitis, and fatigue.
All very common with this mechanism.
But when you consider a patient who was already physically depleted from previous platinum and IO therapies, layering on severe stomatitis or painful paronychia is a non-trivial clinical challenge.
No, it's tough.
For a patient who has already been through the ringer, how manageable are these skin and nail toxicities in a real-world clinic outside of a highly controlled trial environment?
This raises an important question, right? The perpetual tension between oncologic control and the patient's daily quality of life.
Exactly.
The AEs you listed are significant, definitely, but they're also highly predictable.
Right.
These are the classic on-target toxicities we anticipate with robust EGFR and MET inhibition. Any clinical oncologist who has managed patients on cetuximab or the various TKIs is intimately familiar with the dermatologic footprint of these pathways.
Yeah, the ectiform rash and the paronychia are hallmarks of the mechanism actually working.
Exactly. And we have established dermatologic protocols for these specific issues.
Right, we're not flying blind here.
The key, as we've learned over the past decade, is proactive, prophylactic management rather than reactive scrambling.
You don't wait for the grade 3 rash to develop.
No, you initiate the oral tetracyclines, the topical steroids, and the emollient regimens prophylactically from cycle 1, day 1.
And that proactive management is precisely why we must look beyond the raw incidence rates of the AEs and focus on the discontinuation rate.
Absolutely. The discontinuation rate is the ultimate arbiter of real-world tolerability.
If it's too much, they'll just stop.
Right. If the side effects are truly unmanageable, the patients will self-select off the drug, or the clinician will be forced to halt therapy. But in the OreGami-4 cohort, only 6% of patients had to discontinue treatment due to treatment-related adverse events.
Wow, only 6%.
Just 6%.
A 6% discontinuation rate in a trial with a heavy burden of dermatologic and mucosal toxicities is a critical metric.
It is the defining statistic for the safety profile.
It really is.
It confirms that while the skin, nail, and mucosal toxicities occur at high frequencies, our existing supportive care protocols are sufficient to keep the vast majority of patients on therapy.
Yeah, 94% of the cohort was able to push through the toxicities.
Likely utilizing dose interruptions or localized supportive care, sure, but they continued deriving the benefit of that 47% ORR and the extended PFS.
So, when you synthesize the operational convenience of a subcutaneous injection that keeps the patient out of the infusion chair, combined with a highly manageable 6% discontinuation rate, you are looking at a highly practical, deployable regimen for the community oncology setting.
You really are. It checks so many boxes.
So what does this all mean? If we synthesize this deep dive for you, the ASCO 2026 data from the OreGami-4 study delivers a very clear message.
Very clear.
Targeting both the primary EGFR driver and the MET bypass pathway simultaneously via subcutaneous Amivantamab is a highly active strategy. For patients with HPV-unrelated recurrent or metastatic head and neck cancer who have exhausted their standard platinum and immunotherapy options, this dual blockade delivers rapid clinical responses in just 6.6 weeks.
That speed is so important.
It delivers a 47% ORR, nearly doubling historical benchmarks. It extends the median progression-free survival to 6.8 months.
And all while maintaining a safety profile that allows 94% of patients to stay on the drug.
Exactly. It takes a clinical landscape that typically feels devoid of strong options and introduces a highly logical, highly effective new tool.
The data provides a compelling rationale for adopting this bispecific approach in the refractory setting. But, looking at the profound efficacy of shutting down both pathways simultaneously leaves me with a broader, somewhat provocative thought.
Oh, what are you thinking?
It's regarding the future trajectory of HNSCC management. The OreGami-4 investigators strategically excluded patients who had received prior anti-EGFR therapies to test this dual blockade in a clean window, right?
Okay.
Well, if subcutaneous Amivantamab becomes the established standard of care for these heavily pretreated EGFR-naive recurrent patients, how will this data disrupt our entire sequencing algorithm?
That's a great question.
I mean, if we know biologically that the tumor is highly likely to utilize MET as an escape route the moment we apply single-agent EGFR pressure. Will we eventually move this dual targeting mechanism into even earlier lines of therapy?
Oh, wow.
Are we looking at a future where we deploy the bispecific blockade immediately in the first-line recurrent setting, essentially cutting off the tumor's escape routes before they even have a chance to develop?
Rather than holding it in reserve for when the initial therapies inevitably fail,
Exactly.
it proposes a complete paradigm shift, moving from a reactive stance, waiting for the tumor to evolve and then trying to salvage the situation, to a preemptive strike against the resistance mechanisms themselves.
Precisely.
Well, the data we've unpacked today suggests the conversation is no longer theoretical. It is imminent.
I completely agree.
And that is exactly where the field needs to be heading. Thank you for joining us for this deep dive.